Hi all, welcome to another session of vertical integration classes aimed at undergraduate students. Today we have a topic which truly warrants a multidisciplinary approach even in treatment, where the etiologies could range from pure hematological to infectious diseases to hepatic to drug-induced and likewise. For this topic, that is thrombocytopenia, we have a very distinguished panel to discuss. Let me introduce the panelists first. We have Dr. Deepa Madam, from the Associate Professor from the Department of Physiology, Dr. Reema from Pathology, Dr. Girish Kumar Sir, and Dr. Veena Madam, who is heading the Transfusion Medicine Department. I will start off with a question to Deepa Madam. Madam, can we have a quick note on the morphology and the lifespan of platelets to start with?
Yes. If we speak about platelets, it is the smallest of the formed elements. Smallest means it has a diameter of 2 to 4 microns. Compared to RBC, it is 7.2 microns, and for a WBC neutrophil, it is 10 to 14 micrometers. And coming to, even though it is the smallest one, it has got its own function. And its structure, it is also non-nucleated like RBC, but it has got mitochondria. Okay. So by which ADP and ATP can be produced. Then its importance comes in the granular contents. It has got two types of granules, alpha granules and dense granules, in which in the alpha granules the protein contents, protein substances which are to be liberated like the von Willebrand factor, then platelet growth factor, then some of the clotting factors, factor 5, factor 12, then fibronectin, so many things. And in the dense granules comes the non-protein substances, calcium ions, ADP, ATP, then this serotonin, 5-hydroxytryptamine, that's all. Then another important thing is in the outside membrane, there are so many receptors are there, like ADP receptors, then glycoprotein receptors for von Willebrand factor, then for fibrinogen, collagen. These are very important for its function. Then coming to the platelet count, it is irrespective of the sex and age. The normal count, that is 1.5 to 4 lakhs per millimeter cube. Not like RBC and all, according to sex and age, it will vary. Okay, now it is this there. And above 4, we'll consider until it is thrombocytosis, and below 1.5, generally thrombocytopenia, but that is not the critical value for thrombocytopenia.
Okay. Just extending on that question, once we are clear regarding the morphology, can you tell about the thrombopoiesis mechanism and also the role of thrombopoietin in it?
Okay, sure. Like according to the monophyletic theory, all the blood cells are derived from the common pluripotent uncommitted stem cell that is called hemocytoblast in the red bone marrow. From that, it will differentiate to form the committed stem cell, that is the myeloid series of stem cells. The other one is lymphoid series, that will be ultimately form only lymphocytes, but in the myeloid series of stem cell, again differentiated to form the progenitor cell, the colony forming unit mega, that is for the platelets. Then it will be divided to form the first identifiable, that is the blast cell for platelet, that is megakaryoblast. Then the cell size, it will be increased. Initially it will be around 20 microns, it will be increased. Then again it will be more growing, and it form the promegakaryocyte. It is bigger than the megakaryoblast. Then again it will undergo growth and form the precursor of the platelet, that is megakaryocyte. Okay. In contrast to this erythropoiesis, here the size is increasing. And even though the platelet is the smallest one, but the megakaryocyte, the peculiarity is it is the giant cell or the largest cell in the bone marrow, megakaryocyte. And from the megakaryocytes, these platelets are formed by just pinching of the bits of cytoplasm. So in this state, the granules will going on increasing, the cytoplasm will be increasing, and there will be a demarcation in the cytoplasm and put out little bit pseudopodia-like projections into the blood vessel wall, and finally these platelets are released by pinching of the cytoplasm, and one megakaryocyte will approximately produce around 1000 to 2000 platelets. According to the needs of the body, this will be more. And definitely there will be a feedback control system. So whenever the need is there, and if there is a reduced number of platelets, there will be increased formation, and that is stimulated, that is by thrombopoietin, a protein, especially that is liberated from this liver and also from spleen, bone marrow. And the thrombopoietin will stimulate the formation of platelets from the megakaryocyte. That's it. And also interleukins 1, 3 and 6 will help in the initial production of thrombocytes. That's all.
Thank you, ma'am. Now, since we have got an idea about the normal, moving on to Dr. Rima. Rima, from a pathological perspective, how do you classify the causes of thrombocytopenia?
So thrombocytopenia can be either due to reduced production or it could be because of increased destruction. So reduced production means basically your bone marrow is affected and it is getting your megakaryopoiesis is getting suppressed. So that could be either because of aplastic anemia, or it could be because of some nutritional causes like B12 folate deficiency, or some infections or drugs are suppressing your marrow, or it could be hematological neoplasms, malignancies like lymphoma, leukemias, myelodysplastic syndromes, or even metastasis from some other solid organ malignancies. The other increased destruction could be either immune mediated or non-immune mediated. The immune mediated, we have our immune thrombocytopenia, ITP, or we have the post-transfusion purpura, or we have heparin-induced thrombocytopenia, or any autoimmune conditions, SLE, rheumatoid, Hashimoto, etc. And the non-immune causes will include something like your TTP, HUS, DIC.
Thank you. So, you have listed the various causes of thrombocytopenia. Girish sir, what are the common clinical features with which a patient is going to present, and is the symptoms going to vary based upon the severity of thrombocytopenia?
Okay. So first of all, we should know thrombocytopenia can be a symptom of some other disease,
Right.
or it can be a primarily disease of the bone marrow. Like whatever it is, the clinical finding in a patient who is having thrombocytopenia is purpura. That is the most common finding seen in all patients. Purpura means small bleeding in the subcutaneous plane, but they are not blanching. When you see that they are not raised, but they are not blanching. That type of purpurus you can see, but it may not correlate with the number of platelets. It also depends on the function of the platelets. Suppose a patient who is taking aspirin, clopidogrel, and even if the platelet count is 50,000, you can see the purpurus. But in another type of patients, even if it is very low, like ITP patients, if it is 10,000 also, you may not see the purpurus. But purpura is the classical finding of thrombocytopenia. But other associated features like other diseases like SLE-induced thrombocytopenia, you can get SLE rashes, skin rashes can be there, hair loss can be there. Patient who is having liver disease, patient can have shrunken liver, splenomegaly can be there. Like depending on the disease, you can get various types of clinical findings. But as such, thrombocytopenia has got only one clinical finding, that is purpura. If the, like you told, second question is whether it is vary with the severity or not. That is correct. Because initial phases you can only get bleeding into the subcutaneous plane. But after some times, like if the thrombocytopenia is severe enough to produce a major bleed, you can get retinal bleed, you can get stroke, you can get bleeding to the like muscle, everywhere you can get bleeding. But unlike coagulation defects, massive bleeding cannot happen in this type of condition. Small bleeding, but you can you know that if there is a small bleed in the cerebellum, patient will have severe symptoms. A small bleed in the cerebrum, patient will have mild problem. Whereas coagulation defects like liver disease, the bleeding can be massive. It can bleed into the even to the joints. Here that may not happen. But wherever the bleed is there, that type of clinical findings you can get. But the classical finding is purpura, not ecchymosis.
Okay, sir. I'll come back to Deepa, madam. Madam, one of the major function of the platelets will be in the hemostasis mechanism, right? So, what are the steps involved in the platelet plug formation?
Okay, first of all, what is hemostasis? Okay, so it is a physiological process of arrest of bleeding, but while maintaining the blood in the fluid state in the vascular compartment. And for that, there are 3 steps. First, vasoconstriction, then platelet plug formation, that is temporary, and then finally by the definite clot formation. So, in the all the steps, the platelets have role. Okay, and in the first step, that is in vasoconstriction, even though the blood vessel will constrict immediately by mechanical stimulation, but it is contributed by the chemicals released by the granules of the platelets, that is serotonin and thromboxane A2. And in the next, immediately, that is the platelet plug formation occurs. So that is by the properties of the platelets, that is platelet addition, platelet activation and platelet aggregation. So in the normal state, the platelets will not adhere to the vascular endothelium because it is smooth and has a glycocalyx coating. Whenever there is a small injury, the underlying subendothelial collagen get exposed. Right. So these platelets will get attracted first by the von Willebrand factor that will be small, will be there releasing from the vascular endothelium, that will get attached to the collagen, and this platelet has got receptors. I told earlier there will be receptors. Through that it will be attached to the collagen. So the bridge is von Willebrand factor. Then it will activate, and activate means it will attract more platelets, and this activation, it will swell up and put out pseudopodia, and it will release the contents of the granules, so that there will be the ADP will be get out, fibronectin, all these things will be get out, and also there will be thromboxane A2 formation. That will cause more aggregation. Aggregation means the addition between the plates. First of all, it will adhere to the blood vessel, then more addition with the other platelets. That is called aggregation. So only after this aggregation, the platelet plug will form. So this thromboxane A2 formation is by the membrane phospholipid present on the this membrane, the platelet membrane. Okay. So whenever there is activation, an enzyme phospholipase A2 will convert it into arachidonic acid first, and by releasing an enzyme, cyclooxygenase enzyme, it will be converted from the arachidonic acid. Thromboxane A2 is formed, and it is very important for the platelet aggregation. Right. And in this instance, I will tell the rationale for using drug aspirin in preventing or in the prophylaxis of myocardial infarction and also prevent clot formation. So this aspirin drug will inhibit the cyclooxygenase enzyme, so that the thromboxane A2 formation is limited. So that will help in preventing the platelet aggregation. So more and more platelet get aggregated, and the other contents also, fibronectin like, that will increase the stickiness of the platelet. So it will cause more and more, as opposite the cascade of reaction, it will aggregate into the injured part, and it get temporarily sealed off. And this action will not be more prolonged. That will be by the definite clot formation. In the clot formation also, this platelet has action. It will release the platelet activating factor, and release of calcium, and release of other some clotting factors. So in that also, this platelet have importance. And finally, a process called clot retraction. That is the volume of the clot will get decreased by releasing serum. Then only the clot becomes more firm. In that process also, the platelet product thrombostenin is needed. So in all steps of hemostasis, platelet have function. Most important is in the temporary platelet plug formation. Okay.
Thank you, ma'am. Veena ma'am, there will be situations where we need to transfuse platelets, right? So what are the usual indications for platelet transfusion, and also what is the usual threshold?
We need to transfuse platelet either prophylactically, that is to prevent bleeding, or therapeutically to control or to treat bleeding. So the various guidelines are set to help the clinicians to decide the situations where we should go for platelet transfusion and to avoid inappropriate transfusions. That is the purpose of setting platelet transfusion thresholds. So there are various societies which have taken evidence from the literature and formulated guidelines. For example, randomized control trials where have compared the outcome of patients who have received transfusion at a threshold of 20,000 and those who have received transfusion at lower counts or even higher counts. So in some of the RCTs, it has been found that the outcome, that is the hemorrhagic risk, is not different or not significantly different between the groups which receive transfusion for a count of 10,000 and 20,000. So following the restrictive transfusion protocol, 10,000 is set as a threshold for a patient who is a stable non-bleeding patient with thrombocytopenia, especially those patients who are receiving intensive chemotherapies or allogenic stem cell transplants, etc. But in case of chronic stable thrombocytopenia in conditions like aplastic anemia, the threshold can be lower. Even at 5,000, the threshold can be lower in such cases. Okay, and then suppose a patient is having risk factors for bleeding like fever or infection or associated coagulopathy, then naturally this threshold has to be raised till 20,000. So this is about prophylactic transfusion in non-bleeding stable patients. But for patients who are going for some procedure or for surgery, the thresholds are different, because as Madam told, the vascular integrity is important. And platelets have a very important role in this, and we need to ensure that adequate platelets are there in circulation before the patient goes for a surgery. For example, any major surgery, the patient should have about 50,000 platelet before surgery. And for procedures like epidural anesthesia, the threshold is slightly higher at 80,000. And for lumbar puncture or any spinal anesthesia, the threshold level is 50,000. Okay, for central venous catheter placement, the limit is 20,000, and for liver biopsies, especially the percutaneous liver biopsy, it is 50,000, and it can be lower in case of transjugular biopsies. So these are thresholds for prophylactic transfusions. Therapeutic transfusion is to stop bleeding, and that is in case of severe bleeding. We should ensure that the count should be more than 50,000. And for surgical patients or patients who are having multiple trauma, then this count need to be slightly higher or even as high as 1 lakh. And then there are some situations where even though platelet count is low, we need not go for transfusion. For example, some small procedures like insertion of a PICC line or bone marrow biopsy, where the recommendation is that we should apply local pressure and try to prevent transfusion, and also in minor procedures like cataract surgery, etc. So these are various transfusion thresholds. And transfusion is also indicated in cases of platelet dysfunction in patients like Glanzmann's thrombocytopenia or other platelet disorders, and patients who are having platelet dysfunction because of uremia, etc.
Girish sir, can you describe the usual diagnostic approach towards unexplained thrombocytopenia with emphasis to all clinical examination, history, and also the laboratory investigations?
First of all, when we see a thrombocytopenic patients, normally we all have point of care equipment to get CBC test nowadays. But if we are getting a thrombocytopenia in your point of care machine, ideally we have to do a peripheral smear to avoid the clumping of the platelet and get the actual result. We have to send a peripheral smear and see what is the actual platelet in that smear. That is the first step we have to do. Sometimes in point of care it may be slightly lower, and when you get a peripheral smear you can see that it is higher than the point of care equipment. That is the first investigation we do. Then we have to see what is a clinical scenario. If it is an acute fever, thrombocytopenia, then dengue can be there, lepto can be there, malaria can be there. If it is a chronic disease, suppose you get a patient who is having thrombocytopenia, you suspect a viral fever, but after 1 week the platelet counts are not increasing. Normal clinical scenario, by 1 week your fever will subside, patient platelet will improve. But if that is not happening, then you have to strongly think about ITP. To make a diagnosis of ITP, at present what normally doctors are doing, they do a bone marrow and rule out all other conditions and finally come to a conclusion that this is a immune mediated thrombocytopenia. Routine cases, we cannot make a diagnosis of ITP by sending antibodies, all these things, what is explained in the textbook. So we do a bone marrow and rule out leukemia, lymphoma, all these things and make a diagnosis of ITP in that case. But clinically we can see most of these malignant diseases can have a large spleen. Suppose the patient is having liver disease, they can have a large spleen. The splenomegaly itself can produce thrombocytopenia. And when the liver is damaged, liver is the one organ which produces thrombopoietin. So if the liver is damaged, that is not produced. So chronic liver disease with splenomegaly, that itself can produce thrombocytopenia. HIV is another condition, infection, chronic infection where you can get bone marrow suppression and thrombocytopenia, anemia, all sorts of problem can be there. But in a clinical scenario, when you are getting thrombocytopenia, first investigation is peripheral smear. Second investigation is rule out all the infectious causes which can produce thrombocytopenia. Third one will be a bone marrow to rule out the major causes like leukemia, lymphoma, all these things, or bone marrow disease itself can produce thrombocytopenia. Then add-on investigation like your ultrasound abdomen to rule out splenomegaly, shrunken liver, all those things. These are the basic investigation we do in a thrombocytopenia. Clinically, I have already told purpura is a classical finding, and look for any other stroke or other type like retinal problem, visual problem, all these things.
Dr. Rima, sir did mention about peripheral smear and bone marrow biopsies. Can you bring in a pathologist perspective into this?
So, like sir already told, in any case of thrombocytopenia, first you have to make sure that the thrombocytopenia is real and not pseudothrombocytopenia, because the CBC samples are usually collected in EDTA, and EDTA anticoagulant can induce antibodies against the 2B3A of platelets and cause platelet clumping. So, because of that, the cell counters, the automated cell counters may actually miss the actual platelet count and flag it as thrombocytopenia. So we make a peripheral smear, you do a manual platelet count, and you also look at the platelet morphology. Are they large platelets, or is some granularity abnormality is there or not? So or are they microplatelets? So all those you look at platelets. Along with that, you look for the RBC and WBC morphology also, because like sir told, you have to rule out all other causes before labeling the patient as ITP. So you will look for any lymphoma, leukemia, any blast, atypical lymphoid cells, any dysplasias, or any hypersegmented neutrophils in B12 deficiency, or leukoerythroblastic blood picture, which can be seen in metastasis or myelofibrosis. And in the RBCs also, you look for any normoblasts, polychromatophils, any schistocytes are there or not. So all those become important in peripheral smear. And in bone marrow, again, you look at all the tri-lineage. So the erythroid, myeloid, and the megakaryocytes. So megakaryocytes, like ma'am already explained the morphology of megakaryocytes. So we have to look at both the quantity and the morphology. So quantity wise, you have to see, is the bone marrow suppressed, or is it megakaryocytic or not, or are the megs adequate, or are they proliferated in order to compensate for the thrombocytopenia. So, and you also look at the morphology, is there any atypia or any dysplasia or not. And in the other lineages, look for leukemia or any organisms, parasites, lymphomas, myelodysplasias.
Thank you. And both of you did tell about ITP. So if you can just, for the students, tell about the pathophysiology of ITP.
So ITP is actually immune-mediated platelet destruction. So like any other autoimmune disease, it is because of the tolerance to self-antigens is lost. So basically you have defect at multiple levels. One is the T regulatory cells and the dendritic cells are defective. So what happens is the T helper cells, the dendritic cells start presenting our own self-antigens as the MHC to your T helper cells, and because of that the macrophages get activated and the spleen macrophages will destroy all the platelets. So that is splenic destruction. And another thing is B regulatory cells are also affected. So the B cells produce more antibodies, especially to 2B3A, and that causes immune destruction again. And also the cytokines are all dysregulated, complement-mediated lysis also occurs. So that is how immune destruction of platelets happens.
Right. Veena ma'am, basically we did talk about the platelet transfusion. And usually what are the risks or complications associated with platelet transfusion? Also, if you can just tell a quick word about how platelets are prepared also, like in the lab. Yeah.
I'll start with how platelets are prepared. Platelets are prepared by two methods. One is by whole blood donation, where the blood is collected, then it is centrifuged, and based on differential centrifugation, the various components are separated based on the specific gravity of each component. So after centrifugation, you will get three layers, that is RBC at the bottom, and you have a buffy coat in between, which constitutes the platelets, white blood cells, and some RBC, and on the supernatant part is your plasma. So this particular bag, which is formed into the layers, will go into a automated extractor, which will separate all these components into the satellite bags. So now we have one bag with packed RBC, one bag with plasma, and one bag with buffy coat. So another spin is given after 1 to 2 hours of holding time, so that the platelets are separated from the buffy coat and platelet concentrate is prepared. This platelet will be about 50 ml of is in volume. Then another method is preparation using that's called single donor platelet, prepared using apheresis. That is a technique where an automated equipment is used to collect the required component alone. So a disposable kit is used and it is loaded onto a machine which is connected to the donor. So the machine withdraws blood, collects the platelets based on the same centrifugation principle, and the platelets are diverted to a bag, and the rest of the components, which includes the RBCs or the plasma, which goes back to the donor. So this way we are actually maximizing the available donors, because this collection can actually collect more of platelets very safely from a donor. So when you talk about that difference in dose, the thing is that before collecting the donor or before selecting the donor, we ensure that the donor has a minimum platelet count of 1.5 lakhs. And after collection also, the donor will not be losing, or will not his count will not go below 1 lakh. So as we are using an automated equipment, it is much more standardized, and the quality is much more ensured in case of apheresis platelet. And the minimum dose of platelet present in a platelet apheresis concentrate is 3 into 10 to power 11 platelets, whereas in RDP, single RDP, it is around 5 into 10 to power 10. So 6 units of RDP will be replacing 1 unit of apheresis platelet. So from this, it's very clear that the adult dose in terms of RDP, the patient need to be exposed to 6 donors. But the same dose can be provided by single donor when you are using an apheresis platelet. That is the major advantage, because after repeated transfusions or multiple transfusions, patient can develop antibodies against the human leukocyte antigen, which is present in all these components, and they can these alloantibodies can affect the increment of platelet after multiple transfusions, which is called platelet refractoriness. This can also can affect if they are going for a transplant in future. So this is one of the complication of repeated transfusions. So the single donor platelet is definitely expensive than RDP, but the benefit it provides in terms of WBC reduction also, because there is a WBC count is reduced to 5 into 10 to power 6 in case of apheresis platelet, which is almost equal to a leukoreduced unit. So these are the advantages of apheresis compared to RDP. And the second question was about the reactions or the complications of apheresis, complications of platelet transfusion. So we know that every transfusion is associated with risk, and that is why we have to practice rational transfusion and to minimize the number of transfusion as much as possible, because there are immediate and delayed complications for associated with transfusions like febrile non-hemolytic transfusion reaction, which is a very common reaction. It presents in the form of fever and then chills, rigor, etc. And this is mainly because of the cytokines which are present in the units, in the blood components, which cause these reactions. And for preventing that, leukocyte reduction is a method that we can follow, because in leukocyte reduction we are reducing the number of white cells and thereby reducing the cytokines which are released, and this reduces the febrile non-hemolytic transfusion reaction. Then another common reaction is allergic reaction. This can be this is also because of the plasma proteins which are present in the plasma components. So this is important in case of platelet, because we have about 50 ml of platelet in random donor platelet and about 250 ml of 250 ml of plasma in an apheresis platelet. Then another complication of platelet transfusion is transfusion transmitted bacterial infection. That is very important because it is stored at room temperature at 22 to 24 degree, and it is actually acting as a medium for the growth of bacteria. The most common is the skin commensal of the donors, like the Staphylococcus epidermidis, etc. is the commonest organisms, and this can cause severe symptoms in patient like fever, hypotension, etc. immediately or during transfusion itself. So if the patient presents with severe reactions, we need to manage the patient symptomatically, as well as we need to collect sample for blood culture and also send culture from the bag to see whether there is an organism which has grown in the platelet bag and it has caused the reaction. So that is how the transfusion transmitted bacterial infection is confirmed. Then there are other reactions like transfusion related acute lung injury, transfusion associated circulatory overload. All these will happen based on the clinical condition of the patient as well. So these are some of the reactions, and long term or delayed reactions like alloimmunization, transfusion transmitted infections like the HIV, hepatitis B, C, etc. can also happen.
Just extending that question, do you insist on a group specificity for platelet transfusion, and also is there anything specific for pregnant ladies during transfusion?
For platelet transfusion, it is not mandatory that we should always give group specific, but ideal situation is same or the group specific platelets. But because of the inventory constraints, the across group blood platelet transfusion is acceptable by almost all the guidelines. So we can transfuse blood platelets across blood group. Only problem which can happen is, for example, if we are giving an O group apheresis platelet, but the donor happens to be a one with a very high titer of antibodies, then like anti-A and anti-B antibodies in the donor is very high, then there can be a small hemolysis in the recipient, but it is not found to be very significant. Okay, and then Pregnancy. Yeah. In childbearing age group, it is important that we need to consider the RH group of the platelets, because for RH negative pregnant female, it is required that we should give RH negative platelets. That is because of the small amount of RBC which can contaminate the platelet product. It is not that the RH is expressed on the, it is not there, but the concern is about the RBC contamination. Even small volume can cause a anti-D alloimmunization in pregnant female, which can lead to hemolytic disease of newborn in later pregnancies.
Okay. Next question to Rima. Rima, another cause of thrombocytopenia which we usually see in our practice will be DIC. So can you just tell something more about thrombocytopenia and DIC?
So thrombocytopenia and DIC is non-immune destruction. So either due to any kind of stimuli like infection, inflammation, or malignancy, what happens is extensive platelet activation, endothelial activation, which like ma'am already explained, results in multiple thrombus formation. And ultimately what happens is all the platelets and the coagulation factors get consumed because of the widespread thrombus formation, resulting in thrombocytopenia. So it is non-immune cause, unlike ITP, which we learned was immune destruction.
Okay. And also a quick word about TTP for the students.
Okay, so TTP, more than 95% of TTPs are actually secondary TTPs, either because of any drugs or post-transplant or malignancies or pregnancy associated or malignant hypertension or HELP syndrome. All those are what causes TTP most commonly, but 5% of cases can also be congenital, and that is because of the mutation in ADAMTS13 gene, which results in reduced levels of ADAMTS13. So ADAMTS is actually a metalloprotease which is required for cleaving von Willebrand multimers. So these von Willebrand multimers, like ma'am already explained, that is required for your primary as well as your secondary hemostasis. So if the multimers are extensive, then there is exaggerated clot formation. So if ADAMTS is deficient, then the multimers are excess, so there is clot formation is excess.
Okay, right. Great, sir. So now we have discussed most of the conditions which can lead to thrombocytopenia. If you can summarize the common causes which we see in clinical practice and their management strategies.
Okay. So first of all, the commonest disease what we see in our clinical practice is dengue, lepto, malaria. That depends on the area in our country. That these diseases are very common. So normally we don't transfuse platelet first itself, like madam told, we no need to transfuse for all the patients who is having thrombocytopenia. Only if it is less than 10,000, that is a cutoff point for spontaneous bleeding. So there we have to transfuse. Otherwise, patient is on aspirin, clopidogrel, high dose aspirin, clopidogrel, or if the patient is having bleeding tendency, or if you are going for a procedure, like you are going taking the patient for a surgery or taking the patient up for a neurosurgical procedure, then you have to transfuse and keep the level above the limit, like 50,000, more than 50,000 in minor procedures, more than 1 lakh in a major procedure. So that we have to give platelet transfusion. That is a first step. We can give platelet transfusion, but that has to be reserved for patients who is having either clinical bleeding or the cutoff point we keep it is less than 10,000. In ITP, you can even go less than 5,000 because the ITP, the platelets which are produced are very young. They are destroyed outside, so the number of platelets which are produced in the bone marrow are very young, and their efficiency will be more than the normal platelets. So platelet transfusion first. Second thing, you see what is a clinical problem. Like if it is malaria, you treat malaria. If it is leptospira, you treat leptospira. Dengue, there is no other treatment available. You just supportive treatment. Then if it is SLE, like diseases like rheumatic diseases like SLE or something like that, we have to treat the patient for SLE, primary disease. If it is ITP is a immune-mediated thrombocytopenia. We assume that there are antibodies which can destruct the platelet, and we have to give some drugs to avoid these antibodies. Like commonly used drugs are azathioprine or cyclophosphamide or mycophenolate mofetil. That depends on the clinical scenario. We can again select the drug depending on the clinical scenario and physician's knowledge about that. He can select the drug. Third one, like madam told, it is TTP. TTP actually we should be very careful when we are giving platelet transfusion, because platelet transfusion itself can produce more aggregation of platelets and more more destruction of platelet in the circulation. So there plasma exchange will be the treatment of choice. Cryo poor plasma exchange can be given, or if only plasma is available, you can give plasma exchange. These are the routine treatment, but whatever it is, the initial treatment, initial response of a physician will be to give platelet. We have to be very careful. If it is needed, only you give, because we cannot give platelet for a patient who is having 50,000. Prophylactically, you cannot give platelet transfusion, because the duration of platelet in our body, transfused platelet will live only for 24 to 48 hours. The actual half-life may be 1 week, but a transfused platelet may not live like that. So we have to reserve for that. And depending on the clinical scenario, clinical picture, you have to, various other drugs also you can select.
Sir, one thing which we kind of missed in our discussion was this entity called as HIT, heparin-induced thrombocytopenia. Can you just mention something about that, sir?
Heparin-induced thrombocytopenia is not very common, but conventional heparin. That heparin, when we are giving, very rarely you can get thrombocytopenia. But these incidences are very low in like newer generation of heparin, like enoxaparin, dalteparin. In that type of heparin, when you are using, the incidence of heparin-induced thrombocytopenia is less. There are a lot of other drugs other than heparin. They can produce thrombocytopenia due to the action of the drug, or they can produce immune-mediated thrombocytopenia during the treatment with that drug. So they are all possible. Heparin-induced thrombocytopenia is a very, very rare situation because we are giving heparin for a lot of patients. We never see such incident common. It's not a common incident, but you can avoid this by using your newer heparins.
A quick question to Deepa, madam. Madam, how is platelets cleared from the bloodstream?
Okay. So, in circulation, the normal lifespan is around 7 days, 1 week. Okay, and out of the total platelets produced from the bone marrow, 70% in the general circulation and almost 30% is in the spleen. If at all any conditions of stress conditions or increase in epinephrine secretion, there is splenic contraction, and that will be coming into the circulation also. Okay. And some of these platelets will be used up during minor the bleeding hemorrhages occurs, that we are usually unaware of that. Right. And the remaining things after 7 or 8 days, whatever it may be, it will be taken into the spleen, and the spleen is the site for destruction, as well as, even though it is a reservoir too. So in case of splenectomy, the count may be increased. Okay. And also one thing regarding the lifespan, if a patient is using the drug aspirin, so before any surgery, we have to stop the drug in the half-life period, that is within 5 or 6 days.
Right. Question to Veena, madam. Madam, another clinically relevant thing is massive transfusion protocols. How do you incorporate platelets into the massive transfusion protocol?
We see massive transfusion is required in a situation where patient loses about 1 blood volume in 24 hours, where the replacement is given in terms of 10 RBCs in 24 hours, or about 3 or 4 units in 1 hour. So these are the conditions when we say that it is massive transfusion. So in what we do in case of massive transfusion is give a ratio based component protocol, that is to replace whatever is lost in the proper ratio, that is RBC is to FFP is to platelet in ratio of 1:1:1. Some guidelines say it is like 2:1:1 also, that is 2 is RBC and then FFP and platelet 1. This 1 is 1 adult dose of platelet, which will include 4 or 1 STP, that is the dose of platelets which is incorporated. So what happens is that in the early phase resuscitation happens using crystalloids or colloids and packed RBC. In the later phase, the other components are introduced to replace the coagulation factors and platelets in terms of FFP, cryoprecipitate, platelet, etc. So it is said that if you replace or lose about 2 blood volume, definitely platelets are to be included. And as a simple step, maybe we can remember that when we have already transfused around 4 RBC, in the next pack of MTP, platelet should be included. So that is how platelets is incorporated into, and we need to ensure that platelet count is more than 50,000 during any massive transfusion episode.
To Girish sir, so another drug which has gained a lot of interest in thrombocytopenia management is L-Thrombopag. So what is its real role in management of thrombocytopenia?
L-Thrombopag is a drug which is, they are called as thrombopoietin receptor and agonist, like colony stimulating factors, like you have GCSF, GM-CSF, erythropoietin that increases the blood count. Like that type of drugs, this can increase the number of platelets which are produced from your bone marrow. But there are only 2 indications as of now advised by most of the competent authorities. One is ITP. Second one is hepatitis C induced liver disease and thrombocytopenia. Okay. But definitely wherever there is thrombocytopenia, you can try these drugs. Only one problem is it is very costly. The drug itself is very costly. And when we have like facilities for transfusion of various types of platelet concentrates available in most of the centers, these drugs are not gained much like interest among doctors, but they are good drugs. Clinically, as of now, they are indicated in 2 conditions, but we can try in other types of thrombocytopenia also, but they are not as good as like you are using erythropoietin. You can see the visible improvement in the hemoglobin. You are using GSF, GM-CSF. You can see the visible improvement in the neutrophil count, but that much effect is not seen in this type of drugs. But newer drugs are coming. Avatrombopag is coming. Another new drug has come. So after sometimes these drugs also can have a good effect in thrombocytopenia patients.
One last question to Veena madam. Madam, once a platelet is issued from the blood bank, so how long can you keep it outside, and is there any temperature regulation needed for that?
As you know, platelets are stored in room temperature in the blood bank, that is 22 to 24 degree, but it is kept at a constant agitation movement that is optimum for its platelet viability, and that is why that is the best way it can be stored. So once it is issued to the ward, it is said that we should transfuse, or we should start transfusion within 30 minutes, and if not, and if it is not immediately transfused, the best thing would be to return to blood bank to store it at the best and the optimum possible manner, that is agitation and 22 to 24 degrees it can be stored. So once you start transfusion, it should be transfused within 30 minutes or 60 minutes, and maximum possible time is 4 hours for any product to be finished.
Okay, with that we have come to the end of the pre-planned questions. One last round. What are the from an exam point of view, what are the questions with an UG student should prepare from this topic?
Okay, here from physiology, you can tell the role of platelets in providing hemostasis.
Okay, that's the most important question. Rima?
ITP, the pathophysiology, the PS and the bone marrow findings, and the treatment part.
Okay. It's both from clinical and exam.
ITP is the most commonly asked questions in medicine.
Right.
Clinical medicine, when you are examining the patient, you can get a case of purpura. Only thing is, purpura can be due to platelet disorder. Purpura can be due to various other diseases also, palpable, non-palpable. So many different types of purpuras are there. So that also student has to prepare.
No, ma'am, what should the student be knowing from?
I think transfusion reactions would be a common question.
Right. Okay. Thank you. So I hope this was a very interesting and informative session. Thank you. Thank you all.